Hello everyone. Good morning, good afternoon, good evening. I welcome you all to the 12th academic meeting of TUGSS Endoscopy. Over the last 1 to 1.5 years, we have had 12 sessions which were chaired by so many expert panelists from all over the world, from various representing various regions, and we have had wonderful collaborations and discussions when we are taking the topic of the endoscopy forwards. Today, before we begin our talk by Mr. YKS Viswanath, which will be beginning in about 30 minutes, we will first listen to a short video by Dr. Xavier Dray on the topic of endoscopy for foreign body removal. Dr. Xavier is a consultant at the Center of Digestive Endoscopy at Sorbonne University, Paris, France. Before I start the talk, I would like to introduce to you uh, two of our moderators for the session. I feel honored to invite Dr. Tevfik Uprak. Dr. Tevfik has graduated from Marmara University, Department of General Surgery in Istanbul, Turkey, and is currently working as an associate professor at the same university. His main research interests include basic and advanced endoscopic approaches, including endoscopic ultrasound and ERCP. He also serves in the clinic in the field of minimally invasive upper GI surgery, especially benign and malignant disorders of the esophagus. Welcome, Dr. Uprak. Next, I would like to introduce you to the man who doesn't need introduction, the moderator and chief coordinator of TUGSS Endoscopy, Dr. Bhavneet Badla, sir. He is a consultant surgeon and academic director at World Laparoscopy Hospital, Gurgaon. He- Being the chief and coordinator of TUGSS Endoscopy, sir has been instrumental in inviting guests and planning for all the topics and whatever behind the scene discussions that we do for to make sure that the topic of endoscopy reaches more and more surgeons, and more surgeons uh, take up the metal of endoscopy and help in providing better care for their patients. He is also an executive member at the Advanced GI Endoscopy Fellowship Board at Indian Association of Gastrointestinal Endosurgeons. I welcome Dr. Bhavneet Balla, sir. Uh, sir, would you like to speak, or should I directly first begin with the lecture?
Uh, Thanks, Parth. Thanks for the kind introduction. Let's begin with the first presentation of the day.
All right.
Good morning, good afternoon. My name is Xavier Dray. I'm head of the Center for Digestive Endoscopy at Sorbonne University, Saint-Antoine Hospital in Paris, France, and I am very pleased to present this lecture entitled Foreign Bodies of the Digestive Tract, Do's and Don'ts. I have some conflicts of interest. As an introduction, I would like to emphasize that this lecture is based on the following paper published in 2021 in Frontline Gastroenterology, and this paper was based on a high amount of clinical experience with limited level of evidence. There will be more do's than don'ts during this lecture. Why us addressing this question? Because we at Saint-Antoine Hospital, we lead a mobile on-call endoscopy team that covers a 5 million inhabitants area at nights and weekends in the Greater Paris area. Do make varied equipment available to face varied foreign bodies ingestions. Aside to a standard flexible gastroscope, you may consider to use a nasogastroscope in children or to pass a stenosis, a colonoscope or a therapeutic gastroscope with a 3.2 or 3.8 single operating channel, a double channel endoscope, allowing the combined use of devices. You may also consider to use a rigid pharyngoscope that has a larger working channel and a stronger grasp. Numerous retrieval devices are available. The chosen device will depend on the size and shape of the foreign body, but also on the length and operating channel width of the endoscope and the endoscopist's preference and habits. Foreign body retrieval forceps, such as rat tooth, alligator tooth, or shark tooth forceps, are most often used. Retrieval forceps with 2 to 5 prongs can be useful to retrieve soft objects, for footballers in example, but they do not provide a secure enough grip for harder or heavier foreign bodies. Baskets with 3, 4, or 6 wires, such as the Dormia basket, can be used for round foreign bodies. Standard polypectomy snares and retrieval nets are also used and widely available. Balloons can be used for removal of hollow foreign bodies. In addition, special equipment, overtubes, hoods, transparent distal caps must be available to protect the airways and the esophagus mucosa when removing sharp or pointed foreign bodies. Another do. Do secure data collection when you are on call. Decision-making process is mainly based on information received on the phone, on medical knowledge and clinical experience, and on available resources. As the degree of confidence of any information given on call may vary, it is of tremendous importance to note and to archive with a precise timing what has been told by, proposed to, and eventually decided with multiple caregivers, nurses, emergency physicians, intensive care physicians, surgeons, radiologists, and so on. Do anticipate general anesthesia with endotracheal intubation for airway protection for upper GI foreign body extraction. In most non-urgent cases, upper GI endoscopy can be managed without conscious sedation or with conscious sedation without airway protection. Patients must be lying on their left side with the head slightly lowered to reduce inhalation risk. However, in the emergency setting, general anesthesia with endotracheal intubation for airway protection is appropriate in most cases and must therefore be anticipated on call. It is an ESGE recommendation that any patient with hematesis, agitation, or encephalopathy should have general anesthesia with endotracheal intubation prior to endoscopy for upper GI bleeding. It should also be strongly considered for foreign body extraction, particularly for young children, in case of poor patient tolerance, and or when multiple sharp or pointed foreign bodies must be extracted. In any patient with a full stomach, recent meal, active bleeding, foreign body, endotracheal intubation with a rapid sequence induction technique is recommended. Do not plan lower GI endoscopy for removal of a rectal foreign body. Look at this plain radio. What do you think is this foreign body? The vast majority of rectal foreign bodies should be manually retrieved by surgeons under direct vision through the anal route or during laparotomy in case of a complication, impaction of perforation. Lower endoscopy with a little help to remove those large foreign bodies may play a role together with CT scan when a complication is suspected after transanal retrieval of the foreign body. Of note, any attempt to remove rectal drug packs is contraindicated. This is hard to believe, and it is also sometimes hard to pass. Do not go for endoscopy in these cases. Do immediately proceed to endoscopic removal of sharp or pointed objects, even when it is within a food bolus impaction. Any pointed or sharp foreign body should be extracted without delay. In this setting, a recent meal is not a contraindication to urgent endoscopic removal. Again, a general anesthesia performed with a rapid sequence induction technique and with endotracheal intubation must be anticipated in such patients with a full stomach to reduce the risk of pulmonary inhalation. Radiological workup is not mandatory and should not delay urgent endoscopic removal of a pointed or sharp foreign body. Do not delay endoscopic removal of food bolus impaction over 12 to 24 hours. Most food impactions occur in the esophagus. Meat is responsible for most cases in the Western world. Hypersialuria is a sign of complete esophageal obstruction that requires urgent endoscopic removal. In any other case, food impactions should be endoscopically removed within 12 to 24 hours because of the risk of perforation. Radiographs are of little help to confirm the presence and to determine the location of non-bony radiotransparent food bolus in the esophagus. In the absence of any clinical sign of complications, radiological evaluation has a low diagnostic yield and a low impact on therapeutic strategy. It is not necessary in most cases, and it should not inappropriately delay endoscopy. Again, radiological workup is not mandatory and should not delay urgent endoscopic removal of a pointed or sharp foreign body. When absolutely necessary and only when possibly performed in a timely manner, neck, chest, or abdominal radiographs are often sufficient to assess the presence, number, size, shape, and location of radiopaque foreign bodies. CT scan is sometimes needed to determine if obstruction or perforation is present or to assess the presence and number of non-radiopaque objects. X-ray contrast study should not be performed. First, because they may delay endoscopic treatment. Second, because those viscous agents may interfere with endoscopic visualization. Third, because hypertonic solutions can cause acute pulmonary edema when aspirated, and barium is contraindicated when a perforation is suspected. While awaiting endoscopy, pharmacological treatment can be attempted. However, these treatments should not delay any urgent or semi-urgent endoscopy. There is some controversy on the efficacy of glucagon alone or in combination with benzodiazepine or nitroglycerin to ease the passage of the food bolus into the stomach. No significant efficacy of buscopan has been demonstrated yet. Overall, ASGE guidelines support the idea that glucagon is a safe and acceptable option as long as it does not delay endoscopy over a reasonable time. Do immediately proceed to endoscopic removal of burden batteries. Ingestion of cylindrical battery is rare and usually non-severe. On the other hand, the widespread use of large and high-voltage burden batteries is associated with an increased number of ingestions, which can be life-threatening. Most of these cases are seen in children under 4 years. Burden batteries impacted in the esophagus can cause electrical burns, caustic burns, and necrosis, and should therefore be extracted urgently. Do anticipate general anesthesia with endotracheal intubation for airway protection, for upper GI foreign body extraction. Do immediately proceed to endoscopic removal of sharp or pointed objects. Do not plan lower GI endoscopy for removal of a rectal foreign body. Do not delay endoscopic removal of food bolus impactions over 12 to 24 hours. Do immediately proceed to endoscopic removal of burden batteries. Another don't. Don't attempt endoscopic extraction of body pack. Body packing consists of illicit drugs packed within latex condoms or balloons, then swallowed or inserted in the rectum or the vagina. Any endoscopic attempt to remove these foreign bodies is contraindicated because the outcome can be fatal in case of a rupture or leakage of the content. Surgery should be performed instead. Sometimes you must do don'ts. Here you can see the case of a young adult patient admitted for chest pain and hypersialuria 24 hours after ingestion of dozens of narcotic packs. The patient had no sign of shock or perforation. A CT scan showed multiple drug packs along the gastrointestinal tract. Numerous packs were impacted in the esophagus. Despite being contraindicated in theory, due to the risk of rupture, endoscopic extraction was decided as surgical management of this very dilated esophagus was felt at an even higher risk of fistula. The patient was admitted in the operating room at 26 hours of ingestion. The surgical team was standing by in case of a rupture. A rapid sequence intubation was performed given the aspiration risk. All esophageal packs were extracted with a retrieval net and none showed any sign of rupture. The patient was admitted in the intensive care unit for surveillance. He received laxatives to accelerate the passing of the other packs. Follow-up was uneventful. As final conclusions, I would like to add that you should not attempt endoscopic extraction of body packs, but you should build your own local experience and learn when to do don'ts and when not to do those. Thank you very much for your attention.
So thank you, Dr. Path, for that presentation. I would now request Dr. Tawhid to kindly introduce our chairpersons for the session.
Hello.
Thank you, Dr. Bala.
Yeah.
Hello everyone, welcome you all again. I would like to introduce today's panelists. First of all, Dr. Satyapriya Sarkar. He's head of Department of Gastroenterology at GDD Hospital, Calcutta. He has fellowships, VH, FEX, and FAG after completing his master's in general surgery. He's the founder, president of Borderless Doctors, a group of laparoscopic surgeons from SAR countries. He's actively involved in various events, conferences, and training programs of FEX, and he currently serves as the chairman of the board of FEX. He's a very enthusiastic teacher and has trained hundreds of surgeons in the art of advanced GI endoscopy. And Dr. Tawhidul is a surgeon and endoscopist who is in life laparoscopic center. He completed his degree at Bangla Medical College, Bangladesh. After getting general surgery degree, he got fellowship American College of Surgeons and Royal College of Surgeons also respectively. He has been practicing laparoscopic surgery for more than 25 years, and he is the first surgeon to introduce endoscopic surgery in Bangladesh, and he has vast individual experience in this field. Dr. Tawhidul is known as the pioneer of the interventional endoscopic ultrasound and third space surgery in Bangladesh. Welcome, Tawhidul. I respectfully greet the guest, and I'm really excited to hear their questions and comments on this interesting and special topic. Well.
Thank you, Dr. I would now like to welcome and introduce the guest speaker for the day. It's an honor to have with us today Mr. YKS Viswanath. Sir is a professor of surgery at James Cook University Hospital, UK, and is also the president-elect of the British Benign Upper GI Surgical Society. Professor Viswanath has special interest in upper GI gastrointestinal laparoscopic and endoscopic surgery. He has previously successfully led the upper GI oncology team and served as a cancer lead clinician for the trust. Professor has not only established the Stretta Center in the UK and introduced the RESTEC PH studies to investigate GERD, but is also a national proctor for the Stretta therapy. He is actively involved in teaching and training of the fellows and is a recognized national laparoscopic and endoscopic trainer and regularly conducts live training courses. Professor Viswanath has authored numerous publications in the field and is regularly presents at national and international conferences. It's an honor to have you with us, sir. I would now request you to start your presentation. The screen is yours.
Thank you. I'm just thank you very much for that kind words, Bhavan. Let me see whether I can. It's not allowing me to share the screen.
Yes, sir, it's visible now.
Wonderful, thank you. And okay, can you see the screen?
Yeah, we can see your desktop.
Now, can you see?
Yes, you can see, yes.
You can see the presentation. Okay, thank you. I'll just go through it. Okay. Well, first of all, apologies. I got a cardiologist from Bangalore visiting first time into UK, so I have to go and fetch him from he traveled from London this morning to one of the railway stations nearby, so I had to fetch him. So it was not something which I could excuse myself. So therefore, I have to excuse with all of you. And I'm profession, and I'm sort of in nearly 3 decades. I've been in United Kingdom, and I'm an upper GI surgeon. I do esophageectomies, gastrectomies, and things like that. But at the same time, I have developed a huge interest, both from innovative mind as well as a doctor or a surgeon on the advanced endoscopy. So I do everything in the endoscopically upper GI except ESD, whatever you know in your textbook. So, but as a part of it, I developed a huge interest on radiofrequency therapy, and which I'm going to sort of share. Just stop me if you want a burning question in the middle, but hopefully I will sort of conclude this brief presentation in 20-25 minutes. So I don't have any disclosures, but I do sort of closely associated with one of the distributors, CJ Medical, and Restec is the parent company for this Stretta catheter based in North America. So what I want to do is to introduce, this new. It's not new to me. It's nearly, believe it or not, it's more than a decade I've been using a Stretta treatment for selected patients. So my job is to sort of introduce this new technology, to those who don't know anything about it, and to those who are in between their journey of making their mind whether to use it or not. So I'm going to familiarize the technique and demonstrate as live procedure through a small video if it works. And hopefully, most important is, if you do a right procedure in a wrong patient is wrong. Patients will, be befriend with you rest of your life. But if you obviously do a right procedure in a right patient, they are extremely grateful to yourself. So as simple as that, like any of the technology, most important is to learn when not to do and to select your patients. So as a part of this presentation, I'm going to just cover a little bit to other invasive treatments, endoscopic treatments, and develop your understanding based on the evidence and the guidance which is published both in the West as well as in North America. We all know that reflux is common. I tell in majority of my presentations, reflux is as common as a headache. So this talk is not trying to sort of develop a misunderstanding about what is already established in the armamentarium of reflux. So lifestyle, diet, and antacid therapy remains the gold standard, and any of the therapies, whether it's surgery or endoscopic therapy, is not going to rule that out. So, and obviously here my focus will be just on the interventional endoscopic anti-reflux treatment. And I don't think any one of us dispute that PPIs do work and PPIs don't work for everybody due to many reasons. But if you take 100 patients, 30 to 40 patients after about 6 months, 1 year, 2 years, 3 years, they're not satisfied with the PPIs with continuing regurgitation, continuing reflux. But of course, majority up to 70% are happy, and they just, as long as they adhere to lifestyle and diet, they'll be good patients. This was one of the randomized trials 3-4 years back, published in New England Journal of Medicine, clearly stating that in refractory heartburn, interventions such as acid reflux do give a huge amount of long-term remedy, which again is proven again and again. I'm just quoting this as because it's a new publication and it's a RCT. Especially in the last 10 years, our understanding on the PPIs, long-term effects, is becoming better. I do get patients with the first statement is patient with reflux, he has got PPI sensitivity and develops 1, 2, 3, 4. I have seen patients with B12 deficiency, hypomagnesemia, osteoporosis, Clostridium, so many things, and few of them are you can quantify it, few of them you cannot quantify. Therefore, PPI is the answer, but is it the answer for patients to take it 10 years, 20 years, 30 years? I want to just ask the question to yourselves. And when I was in Bombay 35 years back, we used to use medication called cisapride, which was fantastic. And there was, I'm sure few of you may recall, but at the end of the day, it came and went, and because of its ill effects as such. But we don't have a magical prokinetic. We do use domperidone. Again, it comes with some restrictions in Western society. Metoclopramide, we all know it, and we don't have much in the. We occasionally use preclopride in UK, but not often. And other medication which in the reflux I use occasionally once or twice in a year is baclofen. It does have some effect on GABA receptors and used for mainly spasticity disorders, but that's something which again is not regularly used, and it does come with some side effects which I'm sure a few of you who use it often know it. This is just an endoscopy. Just say in this afternoon you're doing an endoscopy. How do you report this? I don't want to ask any questions, but you just look at it. This is a recorded endoscopy, and with a patient with some reflux. So I want to just ask a question to yourself, and then maybe at the end, if time permits, I want you to tell how you would report this. So this patient is begging for help, and the PPAs are not working, and this is what we saw endoscopically. So and then we'll just go through it again if time permits. So esophagus junction, and still I learn, and I was in Oxford yesterday for an annual international meeting, and again we shared a lot of information on the various techniques with French and Belgian colleagues. So there's no question, this is quite intriguing, because as a surgeon, we do see it almost every week when I do laparoscopic, whether oncological or anti-reflux surgery. You have got the cardiac notch, angle of His, and lower esophageal sphincter zone, and the pressure changes, intrathoracic, intra-abdominal. There's so much of dynamics and what I call mechanostressors in this area. It's really, really, if you're a physiologist, you love to learn and understand it better. But to cut short, the barrier function, besides the angle of His, in my opinion, there is a crural sphincter, which is the diaphragmatic outside, which is the right and left crura, encircling the esophagogastric junction. The intrinsic sphincter is the lower esophageal sphincter zone. So the endoscopic therapies usually augment or strengthen the intrinsic sphincter, but not extrinsic. Extrinsic only possible through surgery. So that's something which one has to understand. And by this means that if the patient has got a significant hiatus hernia, endoscopically you can't do much, if that makes sense. So I'll come back to that page. There's 11 to 19 types of configuration of right and left crura and morphology. If you dissect cadavers, I don't know how many of the delegates today are surgeons. But here, what I mean to say is normally the right crust splits and at the top, and then encircles the esophagogastric junction, and inside is the LES, and out, and then it fuses the left side of the right crust, fuses with the left crust, that becomes the boundary for the esophageal hiatus. So there are 19 varieties, I was told, and we do see that often when you do operations. Obviously, if you've got a hiatus hernia, the space between the gullet and the crura increases. That again is a weak spot, allowing the reflux to come back into the esophagus. Whenever I train, especially for endoscopic therapy, I tell, have you seen the A line, which is more of an imaginary line, which represents the top of the lower esophageal sphincter zone. If you watch the distal esophagus when from the middle esophageal end, when it's peristaltic, you understand what is vestibule. Vestibule is between the Z line and the earring. So, and then if there is a crural impression, that means patient has got small hiatus hernia of whatever it is. That's called searing. So I tell them, have you seen ABC? So that itself makes your understanding how you assess the gastroesophageal junction in a patient with reflux, in a patient where you would like to consider for endoscopic therapy. It's not, it is easier for me to tell, but when you do the endoscopy, you understand better from tomorrow when you do it, or the endoscopy. But it's so important, especially if you're considering endoscopic therapy. Why one has to address GORD in a patient with a respectable reflux symptoms? Because if you've got a valve which is weak, it'll get destroyed as time goes on, and it certainly results in a degree of hiatus hernia. The size could vary, and all these reflux changes can cause motility problems with the esophagus. So these are just the 3 factors for you as an endoscopist or a surgeon or interventionist to consider more than what it is. When you have got any of these patients which are depicted in this diagram, they are not suited for endoscopic therapy, which is very, very important. And those patients, you have to consider surgical modalities. Among the endoscopies, about more than nearly 18 years back, we started using what we call injectable silicone, liquid silicone into gastroesophageal junction called Enteryx. And I was exposed to Gatekeeper and Palmer. They're all sort of went and came and went. They're no more used. And of course, I'll be talking a little bit on endoscopic endoplication, which is Isofix, TIF, Muse, or GERD-X, and most importantly, spending a lot of time on Stretta. This is the Enteryx, and you can see here, this is one of our patients about 18 years back, injecting, it comes in 2 vials, and we used to mix it and then inject through injection catheter into the lower esophageal sphincter zone. That's so it actually in vitro, if you combine the 2 solutions, this silicone, that's how it used to form. This is under the microscope. Again, our patient showing huge granulomas. So by granulomatous reaction and enhancing the barrier, this used to work, but obviously, this was fraught with huge side effects, and therefore it was withdrawn from the market. This was partly, it was published, more than 15 years back. It was a nightmare for me to undertake failed Enteryx patients doing an operation with so much of granulomatous reaction. This is a granuloma for one of my patients. So not easy. Another procedure which is quite cheap is arms, but again, I'm not a proponent towards it, and it does cause huge amount of scarring and stenosis that again may contribute to reflux remedy. But again, it's something which needs a lot of research. Another one, which again, those who deal with varices and varicose band, you can just put a few bands on the cardiac mucosa that causes scarring and mucosal ulceration. That again enhances reflux function by enhancing the barrier. But again, this goes through the necrosis of the mucosa, causing stenosis, but it's still not with any evidence for me to say and proponent. So GERD-X is something which is getting popularized by a few colleagues in UK, and few of the Western colleagues use it in Europe. And basically, you're creating, with the help of specialized equipment, an inverted nipple around the gastroesophageal junction through the scope. This is called, it's called GERD-X, and you can see, and you can put a fasteners around the gastroesophageal junction. The scope coming out inverted view. And again, it's it's not only operator dependent, but also it comes with a cost. Israeli technology called Muse, and I have seen it but not used it, and a huge amount of money, and it comes with ultrasonic equipment along with endostapler. And if you just, I hope the video works, and if you just look at this video, and you can see that's before and after, and it's a technology. And again, in my opinion, number 1, the cost. Number 2 is operator dependent. Number 3, you have to select your patient. It has got a stapler cartridge, and it has got an ultrasound, and and there's the anvil. So you've got like a camera, which is more endoscopy, which is more sophisticated with all this technology. So one of the most important factor is ruling out any secondary pathology, and then trying to create angle of his, which is one of the factors which I'm sure all of you know from the point of anti-reflux barrier, and through the technology, you push the shaft, and then you just rotate it, and the angulation and flexibility is good. And with the ultra waves, you know what exactly you're expecting, and you can see the the Fosner's movement, and that would just give that extra safety factor, but it does cost money. So just to sort of coming on to today's subject, which is Stretta. So I want to just read it for you. This patient wrote expressing thank you, and this patient is from Worcester, which is nearly 200 miles from where I practice, and clearly she had she's expressing her gratitude, and she's a young lady of 30s. And you could imagine doing an operation, if something goes wrong, rest of their life, they would not be different to you. So what I'm saying is, this sort of technology, has got a role, and the role we have to define and share our expertise. So I have treated patients from all over United Kingdom, as you could see in the graph, and including from Western Europe, from Germany and France and Belgium. So patients do come sometimes to myself. So Stretta is not an acronym. It is a radiofrequency device, and is used for acid incontinence, basically incontinent lower sphincter zone here. It's equivalent to anal sphincter problems is SECA. Again, obviously, SECA is not as well as popularized like Stretta. So my focus is on Stretta today. Certainly between the invasive treatment and the medical treatment, Stretta has got a role in select patients. Over the last 10 years, various international respectable societies have come out with their own guidance on patients, including National Institute of Clinical Excellence from UK. At the end of this presentation, or you may already know, there are a few always unanswered myths. How does it work, etc. I hope I'll try to unravel those as time goes on. As I said, first 4 slides, when I said in a normal esophagogastric junction, you've got a nicely formed lower esophageal sphincter, nice angle, no prolapse, no reflux. This is normal. And in patients with reflux, this usually because of weak lower esophageal sphincter zone, an increased transient lower esophageal sphincter relaxation, and all these contribute, and angle of his becoming blunt causes acid contents to reflux back. So this sphincter zone will be strengthened by Stretta. I'm sure those of you know links where we place a magnetic necklace around the junction. It just strengthens the lower esophageal sphincter zone from outside, forming a ring or a shell. So that's whatever links is causing at gastric junction is caused by Stretta through internal enhancement of this muscle. So it's a transoral device. We pass it endoscopically. I do 85 to 90% as a day case in endoscopy suite. It does not require GAs, and it has got 30 ml balloon, and it's got 5.5 millimeter retractable stellites, which is like a needle which takes the energy from outside monitor to the patient. So this was the old catheter, and 4 or 5 years back, this a new Stretta catheter was introduced. And the electro energy which is used by these is usually around 450 kilohertz, and obviously it's like a diathermy, but at kilohertz, which causes a meaningful temperature. The software and the technology is so intelligent that if it senses something wrong, it stops. So you don't require to panic. They've got a thermocouple device which modulates the output at this designated temperature, and if the temperature exceeds or does not match the requirements, it just stops. So it's just a closer look on how the thermocouples work. This is the stillet, and this is the end of the catheter, how it looks. One thing which we are not used to, which we have to get used if you are doing, or if you want to plan for Stretta therapy, is bioimpedance. If the needle is in a saturated muscle, which is lower esophageal sphincter zone, it gives a figure of 200-250 ohms, which is bioimpedance, indicating good muscle or at the lower esophageal sphincter zone when you do the treatment. And if it exceeds more than 1,000, that means it's in the fat, and the fat does not can do the electricity like the muscle. So therefore, the bioimpedance goes up if it's in the fat, so it stops. So it's very important to understand what is bioimpedance and ohms as such when you're used to this, when you get used to the treatment. And I will show you the brief video, but one thing which I get asked is, I'm sure all of you probably would have dealt with achalasia with balloon dilatation. Usually we use 25, 30, 35, 40 psi in achalasia patients to disrupt the lower esophageal sphincter zone. Here we use a balloon, which you could see it here, and at the maximum amount of psi which you cause radially when you inject air into this balloon is 2.5. That means the chance of you perforating, as long as you're in the lumen, the esophagus is remote. So the safety profile of this procedure is same as an ordinary diagnostic endoscopy. It's safe, if that makes sense. And usually we deliver at 6 levels, 56 thermal treatments, and so as to cover the lower esophageal sphincter. And this is the check endoscopy after Stretta. You can see the penetrating points. So how does it work? And there's so many, one of hypotheses, and also they have looked at the microscopy and histology changes over a period of time in animal experiments more than 20 years back. Apart from initial inflammation, it does cause collagen deposition, like type 1, type 3 collagens. And then there's a lag phase, and it does cause deactivation of nerves through the vagus plexuses in and around the lower esophageal sphincter zone. That would result functionally reduction of transient lower esophageal sphincter relaxations, which are proven to be higher in patients with reflux. And both the functional advantage as well as the histological barrier strengthening results in decreased reflux. So this is, I don't want to go into details. And, for example, if you do an endoscopy ultrasound scan before and after Stretta, 6 months, clearly the lower esophageal sphincter muscle is bulky. That makes sense. So along with that, functionally, they have looked at it. They looked at complaints. They looked at the LES pressure, including one from South Korea about 3-4 years back. So all these do sort of facilitate and develop, has contributed to our understanding about Stretta. So undoubtedly, we have published maybe 6 or 7 papers so far, and this is just a snapshot of first, I think, 50 or 60 patients. The scores before and after Stretta, including a SF-36 physical scores as well as psychological well-being. There's no question that there's a quality of life improvement after surgery, psychological improvement after surgery, and then obviously the scores from the point of reflux, came down significantly. So the evidence is there, and latterly there are not many RCTs except the reports from various parts of the world about a case or cohort of their experience as such. So I don't want to go into huge details of this. And what I will sort of say to you is really, this is radio frequency, unlike Barrett's metaplasia, dysplasia, where the temperatures exceed 120 degrees and you ablate the mucosa, you destroy the mucosa, you evaporize the mucosa. But here, the radio frequency application, maximum temperature is 80 to 85 degrees, that's achieved. Therefore, it is less than 100 degree. Therefore, I would not call it as application. It's more, I would not call it as ablation. It's called application, if that makes sense. It's a thermal treatment, thermal radio frequency treatment. And another very important thing of, like endoplication or TIF or a GERD-X, which we discussed, it does not alter the structure of the esophagus. That means if you're a surgeon or if you want to repeat the stretta, if you want to do a GERD-X after stretta, you can do that because it's not altering the structure. And again, this is SAGES guidance, including NICE guidance from UK. And this, I just want to share the gist of the Multi-Society Consensus Conference published December 22, discussed in 22 and then published in 2023. And I'll just read it for you. Magnetic sphincter, which is links, or fundoplication are appropriate surgical procedures for adults with GERD, for patients who wish to avoid surgery, and Stretta procedure and transoral fundoplication were found to have better outcomes than PPIs alone. Patients with concomitant obesity were recommended to undergo gastric bypass or fundoplication. This is like obesity patients, I'm talking bariatric group. And of course, patients with who are super obese or coma, they have to have the bypass, which is outside the context of what we are discussing. I have had few patients after sleeve gastrectomy for obesity, they reduced the weight, they got the reflux, and I have done Stretta. And again, this is another challenging area, and again, Stretta has got a role. So I can't sort of, I've done only very few for me to, I can't sort of advise and advocate it yet, but I'm sure there are publications to explaining why one should consider Stretta therapy before these patients go on to gastric bypass. So this was one of the systematic review published in Surgical Endoscopy 2017. Again, clearly says that it's an alternative in select patients as such. And this one was published in 2020. So clearly looking at the Stretta versus PPI for non-erosive reflux with a 6 months follow-up. And as you could see it here, certainly the pressures, they repeated a high-resolution manometry after the Stretta. 6 months down the line, they had better improvement and with PPI cessation, and also the sphincter pressures went up. That's the same a bit more detailed, and they looked at Stretta group, PPI group, look at the number of reflux episodes. Although the PPI group reflux episodes were pretty decent, including acid exposure time, but most importantly, they were still taking PPIs, if that makes sense, and it did not sort of enhance the ileus pressure. Stretta group around 10 to 14, and obviously PPI's group 10 to 10 only. That's expected, if that makes sense. And there's another paper about 3 years back, looking at a 2-pay fundoplication with Stretta in select patients. Certainly, they were, Stretta was equivalent from the point of procedure outcomes, including PPI dependency. And again, in this one, they looked at a Demister score before and after surgery and ileus pressure, and it certainly was matching. And a 2-pay fundoplication, for those who don't know, is 270-degree posterior partial fundoplication. So now we have got Stretta more than 15 years follow-up, and I myself have published recently nearly 4.5 years follow-up, and patients, more than 70% of the patients are remained PPI free or less dependent on PPIs, which is a very positive sign. I think now more than 30,000 Stretta have been carried out, although this slide is old one. And we have got more than nearly 40 published peer-reviewed studies. And there were 3 RCTs, 3 or 4 RCTs, as I was alluding. When it started, the first 15,000, that was 2005, there were 29 adverse incidents were noted. Obviously, there's no technology, there's no procedure, which is called interventional procedure, without side effects or without complications. But as I said, myself has undertaken nearly 280, 300 is imminent procedures for the last 10 years. One patient could not tolerate, developed superior and respectable pain. So we have abandoned the procedure, admitted for 1 night, and then discharged. And then second patient, 3 months later, had a bit of hematemesis, and repeat endoscopy was fine. And I've got third patient who developed aspiration, requiring admission to the hospital, stay for a few days. And so these were 3 patients which I classify as the adverse outcomes, after Stretta therapy. What is my ideal patient? Obviously, it's still, I've got my own endoscopy score, which I have published. If you're planning to do it, please just see whether you can adapt the score. This score was specifically, to the pilot we validated for Stretta patients only. So obviously, patients with reflux who are not tolerating PPIs or do not wish to continue PPIs has got no or tiny hiatus hernia, tiny widened diaphragm, no ulcerative esophagitis, at the most mild or nothing, has got LPR symptoms. And although it says gastroparesis, I'll tell you why. And most importantly, as a medical gastroenterologist, I'm sure the patients which undergo previous anti-reflux surgery, if there's no structural problem, you can do Stretta. Certainly it works. One of the junctional assessment hints, grading called grade 1 to grade 4. This was not for Stretta, just for the colleagues who want to sort of look at and then report appropriately. The Hunt's grading is so essential. You can see here the Z line, as well as a crura, which is Z line is B line, crura is outside, it's a C, they're sinking. This is grade 1. And you can see here, a part of the scope, there's a space around it. It's more of a dilated crura. And Z line and the crural impression is sinking. There's no hiatus hernia. And here, again, there's no hiatus hernia, although people do call this hiatus hernia. But this is Z line. And this is the crura. So they're all sinking. But most important, you can put another scope here, another scope, 3 scopes. This is a dilated crura with no hiatus hernia. But here, Z line is gone up, and that's the crura, that's the B line, this is a C line, and you can see 2 to 3 centimeters. So these patients would not benefit from Stretta. These patients would never benefit from Stretta. So these patients, yes. So I'll come to that. So I don't want to ask a question, how did you repair? So I can't see the A line. This A line is below. This is the B line, which is Z line. This is a C line. So there is a tiny hiatus hernia, which you could say just by looking at it from outside, from inside. But when you do the Z maneuver, usually I would recommend just wait for 4 to 5 respiratory cycles before you take the scope out. Let the patient, distract the patient. And this looks okay, but what I want to say is you can't see the Z line here. Z line has gone up, obviously. The other way you would have seen it. And you can see these gastric folds are going up. That means there's a bit of a weakness or a dilated crura, which will become apparent if you have got a little bit of a patience and then wait. You can see there. You can see, so this will come back to me, big hiatus hernia, or it will come back to me as normal. So both to say it's a big hiatus hernia is, in my opinion, it is incorrect. And to say it's normal is also incorrect. That makes sense. So especially if you're planning for endoscopic therapy, that's what I meant earlier. So as I was telling you, very, very few patients, I do it under GA, but a lot of patients under sedation. And there is, when I do proctorship, where go and supervise, I've got my own tips and tricks. I think it's too much for this webinar, and this is just a video of Stretta, which you must have seen to the YouTube or whatever. That's the stillets taking the energy. That's level 1, which is 10 millimeters above the Z line. And you rotate it 45 degrees. And again, and so that there are 4 needles, 8 treatments at level 1. This is the Z line. The distance between here and is 1 centimeter. This is half centimeter at Z line, below the Z line. And then you take the guide wire out. This is a cardiac where you rotate 30 degrees clockwise and 60 degrees anti-clockwise, because circumference of the cardia is higher, and you obviously deliver more energy. That makes sense. So once you finish, it's exactly 22 minutes procedure. And once you finish it, so over the period of 6 to 7 months, the muscle becomes remodeled and becomes better. I don't want to go into the detail. Obviously, the cost is always there. Now it's nearly $3,000 minimum for Stretta catheter. And, this is all in dollars, but I don't know the current cost. But at the end of the day, the links is for the operation, just for your understanding. But obviously, you have to just look at the surgical cost versus catheter cost, and then you have to sort of make a decision. I'll just see whether I can. Yeah, okay. This is a real patient. But I'm just going to go back. So I'm just sort of measuring it, and this is a real patient. This is one of the private patients usually you measure the gastroesophageal junction that will be fed into the computer to the generator, which you will see shortly. And then I'm just passing the catheter, and you can see the generator. This is the endoscope, and you can see here it's a Z line is barely seen. It's just obviously it's a picture, and most important, there's no hiatus hernia. Gastroesophageal junction and the angle of his is little bit is 45 degrees plus, and then obviously this patient has had reflux, and you can see the guide wire and how you place the guide wire, where you place the guide wire, and vision. There are small tricks which usually do. That's the guide wire, and sorry, and then and passing the catheter. That's the Stretta catheter. You take the scope out after passing the guide wire, and then if say for example gastroesophageal is 40 centimeters, so you start the treatment from 39 centimeters. So this patient, I think, if I'm right, it's probably that's 40 on the Stretta catheter, 39, 38, 37, it's 36.5. So 37.5 was the Z line, and then I'm just inflating the balloon. It has got a pressure valve. That means even if you inflate 100 times, only 30 ml goes into the balloon. I'm just inflating the balloon. And then here, there's 2 gears here. And so that will just, I'm just pressing that. And then that will just take the stillets forward. And here it's important. So 36.5 centimeters Z line, which is here, and the green is the active zone, blue is to be done zone. And this is how it's so friendly. And if you see once or twice, it'll become very easy for you to understand. And here, 37, inside, just imagine this is the esophageal lumen. The inside temperature on the mucosal side is 37 degrees. And again, there's a constant irrigation to protect the mucosal damage. 85 degrees is the target temperature, which is the lower esophageal muscle zone temperature. And 251 represents the outside the tip of the catheter varieties, and 250 clearly is a good number from the point of bioimpedance measurements, saying that the saturated muscle is pretty good and ready to receive the treatment. So this is after 4 levels. You push the catheter inside the stomach and take the guide wire out, and then you inflate the balloon specifically to 25 mL at the cardia, unlike the previous balloon treatments, and then 22 mL after the level 5. So just I don't think you need to sort of assimilate this, what I'm saying. You can see 22 ml, 25 ml balloon. So this is the end result. I just hope you'll see. So you can see the thermal lesions there. So most importantly, so you can see the thermal lesions there. This is post Stretta. I do sort of take a pre and post Stretta lesions, so it's very important to do that from the point of counseling and documentation. So most important is patient selection, and you have to go through the option analysis, document, and then consent. Clearly, it's not for everybody. It's important to understand that. And I don't want to go into GERD phenotype, which is another day. And this is one of the patients of mine, and before and after Stretta, 6 months later, he came for another check endoscopy. You can see it's a bit more firm gastroesophageal junction as such. Certainly, the first series when we published, the 100% dissatisfied patients were, 94% were satisfied after the procedure. Just looking at anything not to miss. Yeah, just for understanding, the level 5 and 6 with 22 ml balloon, you do the cardiac mucosa here, and that has got wider circumference. I use the analogy of inverted umbrella with the spokes, if that makes sense. Yeah, we used sort of standard GERD-HRQL scores, and there are publications which you could sort of see yourselves. And I usually tell patients for a couple of weeks after the procedure, just on liquid to soft diet, and then continue antacid, because you're causing that mucosal thermal lesions for 5 weeks, and then stop it. And then I asked them to take some Gaviscon afterwards and continue lifestyle and dietary measures. That's the advice which I give after the procedure. Yeah, I won't just spend 10 seconds on this. When I do the endoscopy, I look at endoscopy. I do endoscopy, give endoscopy score, and if they've got a dilated crura where you can pass more than one scope, 1.4 per scope diameter, so that again gives an objective measure. Z-line displacement, whether it's syncing or not with the crura, B and C are the same place. If they're not, how many centimeters Z-line is up above the crura, that means distance between C and B. If there's a retrograde or prograde prolapse of the stomach, sometimes retching or whatever, it does cause prolapse. Normally, normal persons should not happen. That's very important to understand. If it's there, just give a point. And preservation of angle of ease is important, whether 45 degrees minus or plus, and depth of the fundus from GOJ and retroversion. If it's 4 centimeter above, 0 points, 1 point for 3 centimeter, 2 points for 2 and 3. So these are a bit of a scores. And if it's less than 5 in the early analysis, the outcomes are better. So to conclude, chairman and faculty, we have got so much of technology and in front of us. So all of us do use any of these measures, whether it's Amazon, Facebook, Google, or Apple. But at the end of the day, you know, so you have to select when to use and what to use. And in my opinion, Stretta has got a role, and I would like to sort of stop it here and then take any questions. Thank you.
Thank you, Professor Viswanath, for that excellent presentation.
No problem.
The house is now open for discussion. I would like to invite the chairpersons first for any comments and the queries. And then later on, if there are any questions in the chat box, Partha can take them up.
Thank you, Professor Viswanath. It was a great, very lucid and extensive presentation regarding the procedure, the selection criteria, how safe it is, and even 8 years follow-up and the perfect indications. It's not being done in my state, West Bengal of India.
Sure.
So theoretically, so many times for years, for 2003, 1, 2, we were thinking about listening to these things, but still it is not being started. But I feel off late, last 3 years, in India, in AIG, in different centers, they're again starting the Stretta, and it's coming back because of its safety, as you have shown. So little pressure you're giving is as safe as the upper GI endoscopy. That's a fantastic procedure, and as chairman of our endoscopy board, I'd ask really first congratulations Valla and Partho for arranging such a fantastic presentation and co-chairing Dr. Tawhidul also to attend. We'll try to make a workshop also, so that I think his learning curve is not very flat. If under proper monitoring, those who are doing a lot, they can go on with the procedure. Few cases definitely after mentoring. So I really very much, I have few doubts, but you have cleared everything. Actually, no question, because I was thinking whether what are the side effects, any strictures after even ablation, even endoscopic dissections, no stricture, no perforation, no bleeding, nothing. Was seeing the pre-stretta and the post-stretta ones, how his classification, how was it, and how it is now snugly fitting the scope. Very much impressed and like to introduce this thing in India sometime for the surgeons also. Thank you.
Thank you very much for kind words. And yeah, no, I'm sort of ambassador from UK to Indian chapter as well. So I held with AIMS or which is the other big hospital in Delhi. One of the institutes with their gang, you know, similar presentation was given, and of course through the endoscopic part of IIG I'm involved to introduce this sort of technology, you know, into India. So there's a question here: is any center offering fellowship or observership on Stretta in India? I don't think so. If your question, but in UK, obviously, you know, I do proctor, and when I started, only center for, you know, for 4 countries in UK is, you know, so and now I do proctor, and around nearly 8-9 centers are doing it in UK. The cost of cartridge of Stretta, you know, it's not reusable, and it's nearly $3,000 minimum. I don't know how much it will cost in India. I don't know how much. I'm sure it's cheaper than surgery. Sorry, it's costlier than surgery. I know that, but end of the day, you know, if you've got money in your pocket and if you want to throw it and you don't want an operation, if you've got a patient, right patient, why not? That's how I look at it. And I have stopped or reduced or prevented surgery more than 50% of 300 procedures which I have done on operation. So can you believe it? So if you're not doing an operation, for example, I don't know how many of today's faculty are surgeons, but you know, so myself, I used to do fundoplications, so many for all these patients before. Now I don't do it.
That's also very important. I think Professor Tawhidul also will admit our patient if they can get away without left fundoplication to the Stretta, and if our like other things in India made, we can make this thing, the cost will be slashed down. So it's
Sure.
a great suggestion.
Mm.
Tawhid, your comment.
Thank you. Thank you for inviting me. First of all, I'd like to thank Professor Viswanath for his excellent presentation. Actually, certain things was not clear to me, but today, after seeing his presentation, many things have been cleared to me also. But question is that one, for this part of the world, it is expensive one issue because $3,000 equal to 3 lakhs Bangladeshi taka. So it is more 3 times expensive than the surgery. Still then, most of the problem is that in our country, our part, we get lots of patients with GERD. I think Dada is doing APC for varieties because I know he's doing this for a long time, one of the part of GERD. So still there, we are doing these sorts of treatment over here with this part of the world. But if these accessories and other things become a bit less expensive, then I think we can start this procedure in Bangladesh, in Kolkata also, because the procedure is not so difficult with our experience, because we are doing ASDM or everything, some fine work we are doing endoscopically. So it would not be difficult for us to do these sorts of procedure. But one query, one question to Professor Viswanath, that you said that after this radio frequency, you have said that muscle become more strengthened. But ideally, there should be some fibrosis, I think. Rather, either instead of becoming strengthening, there should be some fibrosis after using this energy. So, what's your comment regarding this? Which way it is become more stronger, this muscle?
Fibrosis would not make the barrier stronger. No, it becomes weaker and weaker. So Stretta, as a part of a multimodal inflammatory mechanisms, it does cause initial inflammation, some fibrosis, but fibrosis with more of a healthy collagen rather than unhealthy collagen, if that makes sense. And along with that, it just calibrates and makes the myoblast as well as bulky, a small myoblast, hyperplasia of myoblast, if that makes sense. So because, and also its effect on nerves of Kegel, which is partly related to nerve plexuses and vagal nerves. And I don't, if I got a video, I'll show you. I'll just search when I'm speaking. So during the procedure, 50, 60, 70% of patients, pulse rate goes down when I do the procedure. See, when you do any therapeutic EMR, ESG under sedation, pulse rate goes up because of anxiety, pain, and bits and pieces, or dilatation. Here, pulse rate goes down. The nerves in nerve plexuses, especially vagal, are stimulated. So that's why it's been sort of recommended in the first 10 years of indication, gastroparesis. But if you look at why patients will get reflux, one of the things is delayed gastric emptying, gastroparesis, which you don't see always, So it facilitates gastric emptying as well. I can't prove it, but that's been shown in the past. So it's it's not just fibrosis. No. Fibrosis makes any of our part of the body weak, because it doesn't compliance of the lower esophageal muscle changes. So compliance can't become weak if it's only fibrosis.
So thank you, Professor Viswanath, for your excellent presentation. Thank you.
Yes. So I guess there are no more questions. We've already 20 minutes beyond our allotted time.
Okay.
Thank you, Professor Viswanath. Your talk has definitely generated a lot of interest among our delegates, and some of them are interested to. They're actually asking for a training program for Stretta. So maybe in future.
Well, I'm just from the Indian side. Just speak to, there are 2 or 3 reps in India, Stretta reps, which I know. So you have to just put the pressure on, and more than happy, because I do come to India, and actually there are 150 of you are coming next week to Edinburgh
Yes.
from IAGA. So any one of you are coming?
Yes. I'm having the inaugural lecture on Barrett's endoscopic management.
Oh, wonderful. I'll see you in Edinburgh then. So fantastic. So
I think me, Ishar Govindraj was the persons who actually made the all fellowship for endoscopy for the surgeons. Now, 1,400 surgeons are trained, and this year we have made the FAJI, the advanced course for ERCP separately and colonoscopy. Seriously, in future, we can plan some workshop on Stretta also.
Yeah,
It is
sure.
reproducible once the cost is cut down.
Yeah. And there's another question about stenosis. No, I haven't had seen stenosis yet. I know.
Right. So I would like to thank Professor Viswanath and our chairpersons, Dr. Satyapriya, Professor Tawhidul, for gracing this occasion, this webinar, and taking out time on a Sunday afternoon. And thank you so much for being a part of this academic endeavor. And we look forward to meet you in person also very soon.
No problem.
Thank you so much.
Thank you.
We'll end here.
Thank you.
We'll end the
Thank
session
you.
here.
Bye.
Thank you so much.
Thank you.
Thank you.
Bye.
Thank you.